Hello everybody, I am Dr. Colonel S.K. Mathur, practicing endocrine disorders, particularly thyroid. I have been practicing this thyroid disorder for the last 30 years. We are going to talk about what is thyroid and what is hypothyroidism in particular. Because thyroid is the commonest endocrine disorder we see in our day-to-day practice. And it has got wide ramification in everybody's health because large number of comorbidity are associated with the thyroid disorders. So today we are going to talk on hypothyroidism and in particular about subclinical hypothyroidism. This entity, subclinical hypothyroidism, is basically a laboratory diagnosis. The patient or individuals have vague symptoms which can be contributed to anything like fatigue, tiredness, exhaustion, weight gain, lack of sleep, cold intolerance, generalized low feelings, so-called depression sometimes, and large number of female patients who have menstrual irregularities, infertility. So it becomes very important to clinically evaluate these patients or these persons and come to a correct diagnosis so they can be helped by timely intervention. So what we do, we have a high level of suspicion as a doctor on the patient reporting with these kind of complaints. Clinically we evaluate them, assess them, and then a laboratory test called TSS. The hallmark of thyroid disorder is a TSS. Once we do a TSS and assess the value, if it is above normal limit of laboratory value, which is 4.5 generally, and it is more than 4.5 or less than 10 and it's more than 10, then we suspect this patient to have subclinical hypothyroidism. Before we come to a medical plan or treatment for them, we also take further history, if there is any family history of thyroid disorder, or if there are any autoimmune disorder in the family, or these individuals having symptoms for how long. It is for short term, then we can not come to a medication plan. For it is a long-term standing symptom, then we like to evaluate them further and go for the treatment. Now, what all tests we can further do if we see a TSH value of 4.5 to 10? This is called a subclinical thyroid gray area. We cannot start medication to start with. So we do another test called thyroid antibodies, particularly anti-TPO, and then we evaluate these patients further on the basis of their clinical profile, family history, TSS values and anti-TPO. Once we come to a conclusion as a doctor that these are the individuals who can be helped by replacement therapy, the treatment of thyroid is not a medication, it is just a replacement. We call a hormone replacement, and this replacement is given on a daily basis in a small to high doses depending on the requirement. We again like to say thyroid is not a disease, it is a deficiency of a hormone called T4, T3, which is not being produced in the quantity body needs it. So hence what we like to give or say to our patient not to worry about thyroid disorder. It's a lifestyle, or it is just a deficiency. What they need, first the counseling of the patient that not to worry about the disease. It is not going to cause a major harm in your body. So they should be motivated to lifestyle modification, regular diet control, physical exercises, motivate themselves to remain a healthy life. Then the medicine which we call about is a LT4, levothyroxine. Comes in three forms, like many forms in the company: Thyronorm, Thyrox, Aldroxine, the combination of three drugs that they market. So they are given in an empty stomach and a dose which again we start with the low doses and then build up by regularly monitoring the TSS values. So when we give this medication, the guideline to the patient is that take them empty stomach. Empty stomach means they should take first thing in the morning and give a break for half an hour before they eat anything. And another good advice or another important advice for the patient: do not take any PPI like gas medicine. Rather avoid all medication for 3 to 4 hours. Calcium, vitamins, supplements. So they should not be given subsequently or simultaneously with the thyroid medication. So once we start treatment on these patients, we periodically monitor them. The first sign of monitoring is the clinical profile. Have they done any better? Are they improving with the medication? And then of course monitoring the TSS values. So this is a long-term plan treatment. So we should be periodically monitoring them, guiding them, advising them on the lifestyle modification, and then we see how are they doing. Another important point to understand in subclinical hypothyroidism, 5 to 6% of these patients, they over a period of time convert them to overt hypothyroidism, which is a lifelong medication plan. And again, a silver lining Some number of patients, about 5 to 6 again, they spontaneously go into remission and they may not require medication. So periodically monitoring is required. Long-term medication is given for those who come to old hypothyroidism, and number of patients, 5 to 6%, who automatically spontaneously go into remission may need to stop the medication. So to summarize, subclinical hypothyroidism is a challenging task for a doctor and patient both. Once we see the patient of these kind of symptoms as we discussed before, low feeling, tiredness, exhaustion, weight gain, depression, these are the complaints normally the patient come to the doctor, which can be otherwise also or can be because of subclinical hypothyroidism. The other important thing we have to monitor, we should also observe these patients by after giving the medication. One more point I like to say about those female, particularly this disease is very common in the female, 70 to 30 ratio female to male. So if a female patient coming to us if she is in a reproductive age group, we should very closely monitor them and treat them so that they are not having any adverse effect of subclinical hypothyroidism. So I once again summarize, thyroid is a metabolic disorder. Metabolic disorder means it maintains our metabolism, and our metabolism needs that all mental activity, physical activity and reproductive activity depends on thyroid hormone availability. If it is less, there will be compromise in any of these activities. So hence, we must counsel the patient that this is a metabolic disorder where we need to do a lot of lifestyle modification. Meaning by, they should do regular walks, yoga, cycling or anything which is like to do it. Do some physical activity, minimum 35 minutes or 40 minutes a day, 5 days a week to maintain their metabolism to a larger level. Here I want to put a rider, because thyroid hormone replacement is being from the laboratory. It can't be as good as what has been produced in the body. So the lifestyle modification means physical exercise is equally important than medication. They must do medication properly, take medicine regularly, and along with do lifestyle modification, again repeating physical exercise and diet control. Then another important point for the hypothyroidism, what we counsel our patient, if this is not a disease, it's a deficiency. And why the deficiency has occurred, we really don't know the cause. It's a mainly autoimmune disorder. Hence, we cannot cure it. So what are we doing it? We are replacing a hormone to maintain a near normal level of thyroid in the body. So what I normally say our patient, the thyroid is not a disease, it's a friend. Meaning by, as we say in English, friend in need is friend indeed. So look after your friend by taking your medicine regularly, doing your exercise regularly, and periodically monitoring it. It should not be ignored. You should monitor at least once in 3 months or 6 months, maybe once a year if you establish. Thank you very much.